Yohei Sotomi and Mike Gibson coming to you live from AHA 2025, and we're talking about the duration of antithrombotic therapy following PCI in people with AF. Obviously, I had done the Pioneer study looking at this issue in the past, showing that maybe less is more. Interested to see what you found, Yohei.
Yeah, thank you very much for having me here today. So I'm Yohei Sotomi from Osaka University, Japan. So if patients need oral anticoagulation to prevent the stroke, while PCI needs antiplatelet therapy to prevent stent thrombosis. In patients with AFib undergoing PCI, so both antithrombotic and antiplatelet therapy are being performed. However, this dual therapy increases the bleeding risk. So we addressed a common dilemma after PCR in patients with atrial fibrillation. So how long should we continue dual antithrombotic therapy after PCI in patients with AFib? So our randomized trial, so we conducted a prospective open-label investigator-initiated randomized non-inferiority and superiority hybrid trial to determine whether 1 month dual therapy followed by the direct oral anticoagulant alone is as effective as the 12 months standard dual therapy for preventing thromboembolic events while reducing bleeding over 12 months. So we included 1,101 AFib patients undergoing PCI with science everolimus eluting stent, mainly for the chronic coronary syndrome, and prospectively randomized in a one-to-one fashion to either 1 month dual therapy followed by the direct oral anticoagulant monotherapy or 12 months standard dual therapy. The trial was conducted at 75 hospitals in Japan. The primary efficacy endpoint was a composite of death or thromboembolic events. The primary safety endpoint was the bleeding events, including major bleeding and clinically relevant non-major bleeding according to the ISTH criteria. The trial evaluated three hypotheses in a fixed manner. The first one is a non-inferiority of the efficacy ischemic endpoint. The second one is a superiority of the bleeding safety endpoint. And again, third one is a superiority of the efficacy ischemic endpoint. So now moving on to the results. So the primary efficacy endpoint, which is ischemic endpoints, occurred in 5.4% in 1 month dual therapy arm versus 4.5% in the 12 months dual therapy arm. So although the event rate was lower than expected, the upper limit of the 95% confidence interval was within the pre-specified non-inferiority margin of 5%. So the primary safety endpoint, bleeding, events occurred in 4.8% in the 1 month dual therapy arm versus 9.5% in the 12 months standard dual therapy arm, so which showed a significant reduction with the 1 month strategy. So the first one and the second hypothesis were met, and the third one, the superiority of the ischemic endpoint, was not met. So, so in summary, the 12 months risk difference for efficacy was plus 0.9%, while bleeding decreased by 4.7%. So therefore, overall, clinical profile appears acceptable. However, the trial has some limitations. The first one is the trial was conducted only in Japan. So the external validity to other healthcare settings requires confirmation. And the second one is intravascular imaging guided PCI was used in almost all cases in this population, which is very good standard in Japan. So which may not reflect to all global clinical practice. So the third one, the trial evaluated mainly chronic coronary syndrome, which is a stable coronary artery disease. So the caution is required in exploring our results to the acute coronary syndrome. So the last one is the actual event rate was lower than anticipated. So as a result, so the pre-specified non-inferiority margin got relatively large. So in conclusion, so among patients undergoing PCI with atrial fibrillation, so 1 month antithrombotic gel therapy followed by the direct oral anticoagulant monotherapy was non-inferior to the 12 months standard therapy for death or thromboembolic events and superior for the bleeding, which is a major bleeding or clinically relevant non-major bleeding. So suggesting an overall favorable net clinical profile. So however, again, so given the lower than anticipated event rates with fixed absolute margin, so efficacy, especially efficacy should be elaborated with appropriate caution. That's all.
And when you say dual therapy, do you mean DAPT or do you mean a thienopyridine or aspirin plus
Yeah,
a drug?
yeah. So dual therapy, uh, I said is it means the direct and direct oral anticoagulant plus P2Y12 inhibitor.
Okay. All right. So very good. And your margin was 5%, what you pre-specified. What was your relative margin that you pre-specified?
Yeah, so it was 1.5. So we assumed 10% event rates in the control arm, and the pre-specified margin was 5%. So that means the relative margin was 1.5. So you may think that is a little bit wider than usual, but we focused the balance between the ischemic endpoint events and bleeding events, and we assumed the reduction in the bleeding events by 10%. So that's the improvement in the bleeding. So we thought that 5% in the ischemic endpoint was acceptable, but yeah, again, there should be some debate.
So I wrote an editorial about this recently in Jack. When this happens, perhaps you should apply the relative margin. If you apply the 1.5 relative margin, are you still non-inferior?
Uh, you mean, I'm sorry, what?
So
I can,
if instead of using a 5% absolute difference, if you instead looked at a relative margin of 1.5, would your non-inferiority criteria be met?
uh, uh, unfortunately not, because the event rate, actual event rate was about 5%. So
Okay.
the upper limit of the 95% confidence interval was 3.5. So actual event rate was 5%. That means the relative hazard ratio would be 1.7 or something.
And you needed to be within 1.75. I see. Yes. Okay. Well, very good. Thank you. Very carefully done study. You're right. You do a great job in Japan with intravascular imaging. That may lower your event rates more than the rest of the world, making it tougher. on the efficacy side. But congratulations, very well conducted study, very important study. Thank you so much, Dr. Sotomi, for sharing with us today. And thank you for joining us here live from AHA 2025.
Thank you very much.
Thank you.